subcategories. So they are like, the first is like, let's see, like all of us know that ultrasound is the most common modality for assessing cirrhosis, but definitely MRA in the current practice has definitive role. So we'll just try to see how does a cirrhotic liver looks in an MR, and then next category is, as you know, like you have polyps in the colons progressing with the spectrum. So you have focal lesions in the cirrhosis, which have a definitive imaging characteristics. So next part will be to focus on the focal lesions, and the third part will be on Lirads interpretation, and we'll also see why the Lirads came, what is the necessity of it, and how important it is for us to start talking in terms of Lirads. Then we'll have some interactive cases. So MRI cirrhosis, say, what are the key pointers from the MRI cirrhosis point of view? I'll just run a quick video. Okay, this is going caudocranially. Good. So I'll stop at this, and then I will let you with few of the key pointers how you can look. So this is a decompensated liver. So there is an ascites. For benefit of all, just to make things easy, first, like MRI has various spectrum of sequences in the current day world. So in which we have mainly T1 weighted image is for anatomy, T2 is for pathology, and then we have diffusion weighted images, very, very relevant, important for onco imaging, which picks up mitotic lesions, small mitotic lesions too. And then we have post contrast images. Then so T1, as I told, is for anatomy, T2 is for pathology. So remember, T2 weighted image, when a sequence is put in front of you when you are trying to evaluate, if the water content, so in this particular case you will have the ascites. So if the ascites is bright, so remember, as World War II, water is white in T2. So water is white in T2 weighted images. So you can see white fluid. So you are dealing with a T2 weighted image, or sometimes you'll have normal structures like CSF, or you can fluid structures like or urinary bladder or a gallbladder, like that. So you can use these as the reference for you to decide what sequence you are looking for. Then what is the next step? There are a few other modified sequences which have been done, so that, see, now the fat is also white. Fat remains white in T1 as well as T2. It is more brighter in T1 weighted images, but we don't want, especially when you are looking into the ascites and the mesenteric fat, we want to differentiate the fluid and the fat. So that is the time when we start applying something called as a fat saturation or a fat suppression sequences. So you would have heard the word the stir images or T2 fat suppression images. So these are the ones. So in those images, what you see is T2, it's a T2 weighted image with a fat suppressed image. Okay, so these are in, similarly we do it for T1 weighted with fat suppression. So remember, T1 for anatomy, T2 for pathology, and in T2, whichever lesion becomes more brighter or brighter lesions are considered to be pathological. And then thirdly, you have diffusion weighted image and contrast images. So these, if you know these four sequences, I mean, it helps a lot. So here there is an ascites, and also look into the surface of the liver. Surface of the lesion is generally very smooth. You can see here now there is a nodular liver. So this is one of the pointer again to tell that we are dealing with a diseased liver. Then there are few other things, like there is a volume redistribution of the liver. So you can see there is a caudate lobe hypertrophy, there is an atrophy of the right lobe, and also the prominent interlobar fissures. So all these, again, you can see they are nicely seen in the patients with CLDs, right? There was one more. Okay, so this is also the similarly, plus also you will be try to look for any collateral vessels here, collateral vessels. So all these are the enough key pointers. So you can see them, same thing has been given in some these images showing the nodular surface of the liver and caudate lobe hypertrophy, prominent interlobar fissure. And here there are cavernous transformation of main portal vein. There are portovenous collateral vessels in the medial to the spleen and the lienorenal areas. And this particular image, like, is the diffusion weighted image. So this is how you need. You should try to identify this. So generally, it's a very dark image. So in this, there are a couple of structures which can remain normally bright. Is the spleen and the brain parenchyma and ovaries. But rest of the other they remain darker. So any bright lesion, like what you are seeing, this neural structure like a spinal cord, little bright here, a bright kind of lesion sitting in this liver, background liver, suggests that we are dealing with some focal lesions in the liver. Okay, which can be mitotic. Then coming to few ratios, this is mainly for some residents when they just to know that what is the caudate to right lobe ratio. See, caudate lobe is generally delineated by two lines. The line one is just lateral to the main portal vein, and the medial line is just medial to the caudate lobe. This forms the caudate lobe distance, and the other one is to the right side of the surface of the liver. Caudate to right lobe ratio, the study shows that less than 0.6 is normal, 0.6 to 0.65 is borderline. Chances that the patient is having CLD. Then anything more than 0.65, 96% likely, and more than 0.73, it is more likely to be cirrhotic liver. So coming to the MRI features, you can see that volume, we already saw this volume redistribution, reduced right lobe volume, enlarged left lobe, enlarged caudate lobe, nodular surface, interlobar fissure prominence, signal intensity also starts becoming worse, collateral vessels, portal hypertension, and splenomegaly. Okay, so coming to now, we know CLD, and the importance of CLD is like now we have to see these patients, we need to follow them up to look for the nodular lesions. So as you know, in the cirrhotic liver, generally they are having regenerative nodules with areas of fibrosis, right? So the various focal lesions in the liver are divided into a spectrum. So generally, it's quite simple. Like you start with this regenerative nodule, which is the benign nodule. Then you have a dysplastic nodule in the middle, and then you have HCC on the other end of the spectrum. So we'll just try to see how can we differentiate this. And then I want everyone to remember these 5 criterias. That is the arterial phase hyperenhancement. That is the first major criteria for HCC. Then the second one is the observation diameter. So then third one is what is the this is maximum size of the lesion. Third one is the washout appearance. So what is washout? As we know, any mitotic lesion, they will have an arterial hyperenhancement, and then there is an immediate washout in the venous phase. Then there is a capsule, characteristic capsule appearance, and a threshold growth. All these cases, all these images we are going to see quite a few times in next few of our slides to make our interpretation easy. Then what is focal liver lesion? It's by definition a discrete abnormality arising within the liver. It causes displacement and distortion of the portal and hepatic vessels. So you can see that any focal lesion, if it is distorting the vasculature, then we start telling it, or if it is near the surface, it bulges the capsule. If it is near the IVC, these are all visually you will be able to make out. It causes displacement, because sometimes there are many focal lesions like fatty sparing areas, focal fatty infiltration. All these can kind of mimic nodular or mass lesions. Okay, then we'll just look into, before we dive into the Lirads, we just have to understand what are we dealing with, how these focal nodular lesions and how do they appear in MRI. So first is the regenerative nodules. So now we will just go back to the spectrum here. On the left side, you have cirrhotic nodules. Then next comes the low-grade dysplastic nodules. The third one comes the high-grade dysplastic nodules. Next is early HCC and a progressed HCC. What does generally happen as the nodules progress? There will be loss of portal vascularity, and then there is an angiogenesis and increased arterial blood flow. okay, increased arterial blood flow. So this results in causing the arterial phase hyperenhancement. So you can see them here. So this is a cirrhotic nodule, low grade, high grade dysplastic nodule, early HCC and a progressed HCC. So if you look very carefully, these two parts, the cirrhotic part and a early dysplastic nodule, can behave in one type on an MRI. They can be almost similar, sometimes very indistinguishable. And the third, the high-grade dysplastic nodule and early HCC can behave almost have an overlapping features, and progressed HCC will have a classic appearance, right? So now coming to regenerative nodule, how do they appear in MRI? So as I told you, T1 and T2 are our major signal, weightings, what we see initially. In a T1, it can be iso-intense, hypo-intense or hyper-intense. Okay, so generally if it is more bright in T1, then the more chances of it being benign becomes more, right? Regenerative nodule becomes more. Then on a T2 weighted image, on the contrary, it will be low signal in T2. And anything little bright signal, World War II, I told you water. So anything more white on T2, whenever the lesion starts becoming more whiter, brighter, then it tells that it is becoming dysplastic or early HCC kind of thing. Then the diffusion weighted images, you don't see any restriction in diffusion. So on histopathology, these regenerative nodules have they look similar to the rest of the liver parenchyma, except for some kind of delineation or separation from the rest, some small capsular kind of formation. So there is no enhancement on arterial phase, as I told, because they have similar arterial vascular supply like rest of the liver. So it is very difficult for us to differentiate in MRI these nodules apart from these subtle changes in T1 and T2 images. So this is what we are seeing here. You can see that these are the small nodules which are appearing bright in T1, and they are appearing hypo-intense in T2. And then in the contrast, there is no much of an enhancement. The lesions are appearing hypo with the rest of the liver parenchyma, right? And also the regenerative nodules, you can see that they are almost similar to the rest of the background liver parenchyma. Now coming to the next entity, the dysplastic nodule, which we divided into two, low grade more towards the regenerative nodule, high grade towards HCC. What are dysplastic nodule? How do you define it? They are localized proliferation of hepatocytes and they are supporting stroma with atypical cells. They lack, why do we tell? Even they have atypical cells, but they lack definite signs of malignancy at histologic analysis. So in low-grade dysplastic nodule, still the arterial supply is almost the same, and there is a preserved portal venous blood supply. There is no angiogenesis, and they mimic regenerative nodule. And high-grade dysplastic nodule, they start a little bit of there can be a portal vascularization. There can be loss of portal vascular flow. And there can be a start of angiogenesis, but not to be the real extent what you see in HCC. So they can generally be little hypovascular at the early part, but sometimes they might also gain in vascularity without real neoplastic changes. Still they'll have dysplastic cells. So this high-grade dysplastic nodule can mimic like a early HCC. See, now this is a 67-year-old female. You can see that there is a small, I have just marked it for ease purpose. Like you can see, this is a T1 weighted image. You can see that the CSF is hypo here, right? And the ascitic fluid is also hypointense. You can see the lesion is little, almost equal or mildly increased than that of the background liver. Okay, so then we tell it as hyperintense. Then you can see the nodule is little brighter than the rest of the background liver parenchyma. So it is hyperintense in T2. Then in diffusion weighted image, you don't find anything really bright stuck up like a star. You should see like something like a star, bright stars here, but you don't find anything like that. Then in arterial phase, there looks like a small dot of enhancement here. Arterial phase, there is some amount of enhancement. But in venous phase, you don't find a classical washout. I will tell about how does the washout looks. You should just try to look into the background parenchyma, and there is no capsule here. So this suggests that we are in a it's a dysplastic nodule. Then what is the concept for HCC characterization? As I told you, 5 important things. Arterial phase hyperenhancement. So that too, they tell this as a non-rim type. It should not be having a complete circularity, because there are few other things like peripheral circular things can come in cholangiocarcinomas, or peripheral interrupted things can come in hemangiomas. Like, so that's why it's basically so. But what we have to just remember is it is an arterial phase hyperenhancement. Second one is observation diameter. See, even the observation diameter, whenever you get the reports, people measure it in a different ways and give it. So, but there are 3 important thresholds for which are useful in Lirads for us to characterize. So, in order to get an accurate Lirads, it's very important that we know what does this observation diameter means. Next one is washout appearance of the lesion, capsule appearance of the lesion, and threshold growth. So these are the key imaging features which finally leads us to a standardization of reporting through Lirads. So in these 2 images actually help us to understand what is arterial phase hyperenhancement. You can see that this lesion is almost uniformly enhancing, hyperenhancing. See, this is how do you know that this is an arterial phase? See, please, for all practical purpose, whenever a post-contrast images you are trying to look, first I think I want you all to put it on the vertebral body, then go just anterior to it. So you will find 2 structures. One is the rounded, and the other one is generally it will be oval shaped onto the right. So the one usually on the left, most of the times you can see that this is aorta, well defined, rounded. And if this is hyper enhancing and the adjacent structure is not enhancing, that is the vein, then you know that you are dealing with an arterial phase. So in an arterial phase, if you find an intense enhancement of the lesion, then you know that this is an arterial phase hyperenhancing. Now next comes is, as far as liver is concerned, how do you diagnose what is portal phase? Portal phase is, you can see arterial enhancement can still continue to remain bright, but it may be lesser brighter than the actual arteriogram phase. Then there will be an enhancement of the portal veins. You can see the portal radicals, portal veins nicely opacified. And then when you scroll the images up and down, you can see that there is still no opacification of the hepatic veins. So that is when you are going to tell that is a portal phase of the liver. Then thirdly, we tell venous phase of the liver when you find that the aorta has quite become lesser in density, enhancement of the contrast. Then portal veins are enhanced, as well as the hepatic veins which drain into the IVC, they are also enhanced. So when all 3 things are there, then you know that you are seeing the venous phase of the liver, right? So now coming back to arterial phase hyperenhancement, this is an example showing that entire lesion is enhancing, and they also told for Lirads, even if the nodule is bigger and even a part of the lesion shows an hyperenhancement, which is called as a nodule in nodule appearance. So even this should be considered as positive for arterial phase hyperenhancement. So this is one of the criteria, either whole of a lesion or a part of a lesion hyperenhancing. So for ease of understanding, you can see that this is a plain image and no enhancement. So you can see that aorta and IVC here, and you can see that the aorta is enhancing well and arterial phase hyperenhancement is there, right? So coming to the second important criteria is the diameters. So they use mainly the three levels, like that is 0 to 10. So 10 becomes one of the important landmark for the nodular size, and then another one is 20. So 0 to 10, 10 to 20, and more than 20. So for this, so 10 millimeters and 20 millimeters. So we need to be little accurate. So for ease of understanding of and measurement, see what generally has been advised is that the lesion has to be measured from outer edge to outer edge, and it should also include the capsule of the lesion, and it should be the single long dimension of the lesion. So if you measure like this, it may come 2.5. If you measure like this, it may come 3.5 centimeters. So for us, we are interested in this long dimension of the lesion. Then there is an entire observation of the lesion. See, sometimes there could be some enhancing areas, some non-enhancing areas. So how to measure it? So you have to include both enhancing as well as non-enhancing area entire observation in your lesion assessment. Similarly, this is another case where the enhancement area is different, nodule in nodule appearance. And there sometimes can be like a normal liver parenchyma can show little bit of corona-like enhancement, parenchymal enhancement. So those can be excluded. If there is subtle enhancement without mass effect, just those things areas, only the lesion nodule to be taken. So these are the precautions we need to take when you are measuring the lesion. Then coming to what is the washout, this next criteria is the washout of a lesion. So this, you know that this is an arterial phase hyperenhancement, and so in the portal phase or a portovenous phase, you can see that the lesion washes off. You can see nicely that the lesion washes off, and it is almost little lesser than the enhancing background parenchyma. So this is called as the washout of a lesion, and you can see that hepatic veins taking up the flow here. Then coming to the next major criteria, that is the capsule. So what do we mean by capsule? So after the venous phase, that the delayed phase images, immediate delayed phase images show that in addition to the washout, you can see that a thin rim of capsule forms around the lesion. So this is what is called as a capsule appearance of a lesion. Again, this is the hallmark of the HCC, right? So coming to this particular set of images where plane it's normal, it is hyper-enhancing. Now here this is the washout phase, washout of a lesion. This is the capsule of a lesion. So we'll have interactive cases at the end where we will try to see all these cases, and you will all be able to do Lirads on your own. Then coming to the fifth criteria, see, whenever we find some smaller lesions, we would or some lesions at Lirads 3, we would like to do a interval scans. So whenever you find an interval growth in less than 6 months, if the interval growth is more than 50% size increase, then we take this as one of the major criteria and put it as like there is definitely one of the major criteria for HCC. And there are few other things which are in the, this was earlier taken as the interval growth, like more than 6 months with more than 100% increase or less than 24 months new observation. In the current Lirads version, these are taken as a sub-threshold growth criteria. So these are considered as an ancillary features, but not the major feature. Now, so now we have seen about liver, we have seen about the different focal lesions of the liver. We have tried to understand the various patterns, how they look. But whenever you get across a report, in India at least, the compliance is much still low about Lirads. So it's very, very important. Many times you come across these reports like may represent HCC, worrisome for HCC, HCC not excluded, suspicious, equivocal, and it means very difficult for the surgeon, oncologist, oncosurgeon, or the interventionist to see. I mean, they don't know which one to act upon, what to do, and all like that, because there is no clear-cut clarity in the diagnosis, in the final diagnosis. So it's quite confusing. So that's the reason why there was an attempt and for a standardization that for interpretation and reporting, so that terminology becomes standards, whether you are in India or abroad or sitting anywhere, the reports of the nodular lesions can be same. And also this led to very good treatment decisions and the recommendations. Also in the nowadays AI era data collection, and it has become more simplified. So this was Lirads was developed by the International Consortium of Diagnostic and Interventional Radiologists, Hepatobiliary Surgeons, Hepatologists, and Hepatopathologists. This was mainly designed to improve communication and patient care and Lirads is consistent now, and it is fully integrated into American Association of Society for Liver Diseases, NCCN guidelines, and organ procurement transplant network. So all this, it has been already been incorporated. So this is what we are looking into it, the current version of Lirads. But I'm not going to bore you with this, but instead I'm going to simplify it. And I think by the end of the talk, I think you will be in a position to, when you go on to your packs, you will be able to Lirad it by yourself. But this CT MRI diagnostic table, you can just Google it and you can have it on your screen or on your mobile, so that you start practicing it. Right. So of all this is very, very important, and these are little more next level when you start reading it. Then when you get a tie breaking situation, when you know that is it 3 or 4, when you want to upgrade or downgrade. So there have been a few ancillary features which favor malignancy, which favor benignity, and based on these features, so presence of one or more features, you can upgrade these lesions. And the Lirads has told for LR5 it has to be exclusively all major features should be there. So we cannot upgrade from LR4 to LR5. But similarly, if the patient is having benign features, you can still keep downgrading, right? So this helps you in tie break and some kind of situations by using the ancillary features. So I want everyone to focus on this table, and I'm just trying to simplify this now. So you can see that there are 3 rows. We have seen 5 major features. So in which the first major feature comes in the first row, and then the size of the lesion comes in the second row, and then the other 3 major features like the capsule, the washout of the lesion, and the interval growth, threshold growth, all are clubbed in one group. And here, presence of none of these 3 features, presence of one of these feature and presence of 2 or more of these features are to be considered. Then in the column wise, we just divide it into the arterial phase hyperenhancement criteria, and that is very simple. Arterial phase, whatever the lesions are enhancing, they are clubbed under this group, and whichever are not enhancing in arterial phase are clubbed under this group. So in arterial phase hyperenhancing group, they are divided into based on the size threshold. I told you 10, less than 10, less than 20, and more than 20. So these are the 3 columns, sub-columns inside this. And in arterial phase hyperenhancement, since there is no enhancement, we are not going to worry about 10 millimeter nodules. We are just keeping 20 as the threshold, less than 20 millimeter nodule and more than 20 millimeter nodule. Okay, with this, we also should know where all we can apply the Lirads. So Lirads has been recommended to be applied in cirrhosis patients with chronic hepatitis B viral infections, and in patients with current or prior HCC, and they do not apply in patients who are less than 18-year-old, and those patients who have congenital hepatic fibrosis or some vascular disorders like hereditary hemorrhagic telangiectasia, Budd-Chiari syndrome, portal vein occlusions, or cardiac congestion. So we should also know that like a Budd-Chiari, especially which we come across quite frequently, or a chronic portal vein occlusion, then we shouldn't be applying this. Then coming to ancillary features which favor malignancy. So I would just suggest that you know about like 1 or 2, like presence of diffusion restriction. I mean, as I told you, anything restricting lesion is always you can add towards malignancy, and presence of nodular enhancement in a nodular visa, again you will take it as favor malignancy. And if the nodule which you are following it up, it is stable over more than 2 years, then you can tell that this is favoring benignity, and you can downstage the Lirads. So this is the table where you are telling upstaging and downstaging the Lirads. Then this we have already gone through it, right? We have read it. Now, like Birads, so we also have the Lirads, which will help us in treatment plan in all our MDTs. So essentially, LR1 are very, very clear-cut, definitive, typical benign lesions, and LR2 are probably benign. So these 2 categories are like I've marked it in green, so that they are kind of benign lesions where we can just have a surveillance of the lesions, right? Surveillance of the lesion. Then the next category, LR3, where there is an intermediate probability of HCC, then we need to have a short-term surveillance, like say 3 months or 6 months. Then we have LR4 category, which suggests that there is a probably HCC. That is when this becomes an important. We have an MDT, and then based on what type of lesion, what do we want to do, then based on we can even consider biopsy. The definitive HCC, whenever we are seeing definitive HCC, LR5 lesions, very characteristics, there is no requirement of any biopsy, and you can directly go in for MDT, and then you can have a consensus on management, like what do you want to do, some interventional procedures, or do you want to do a resection, or do you want to put the patient for the transplant. Then there are few other things in addition to this LR1 to LR5. You should know what is LRM. LRM is when you feel that the lesion is a malignant cancer, but it is other than HCC, then you are going to put it as an LRM. Generally, this goes to MDT and then they go for biopsy. And LRTIV, that is tumor in vein appearance. Whenever the tumor invades the vessel, then that is when we are going to put them as tumor in vein. And LRTNC is like when the images are not good. Now, there are few situations, few conditions where we are very clear cut. So when we tell that this is a clear cut benign lesion, so we'll try to goes into those categories. Remember the Lirads, the CT-MR imaging table, what I put is for Lirads 3, 4 and 5. So 1 and 2, we need to look into MR images and try to figure out and try to replace them 1 and 2 based on our T1, T2 diffusion and contrast images. So as we know that cyst is quite simple. Cyst is filled with water. So water will be like it will be dark in hypo-intense in T1, and water will be World War II. Water is hyper-intense on T2, and then it will not show any diffusion restriction, not enhancement. So whenever you find across such lesion, you know that we are dealing with LR1. And the next is the hemangioma. Hemangioma have been described. Most of you would have heard. They are by their classic appearance that they have a peripheral interrupted enhancement with centripetal filling in, and they show progressive filling, central filling, and becomes almost iso-intense in the delayed phase images. So this is very classical signature of hemangioma. Then you have other things like perfusion alterations, fat depositions, and some pseudomasses and confluent fibrosis or focal scar. So those are very clear cut. What is this LR2 category? So LR2 category is like, you know that these are cysts, but still sometimes they have some atypical features. There could be a small intramural nodule, there could be some septation, there could be some hemorrhage inside it, or something which bothers you to tell it as a classic benign lesion. So that is when you are going to put. Similarly, atypical hemangioma, some perfusion alterations. I mean, all these, wherever you feel that there is some amount of not a very classic appearance, then that is when you are going to tell it is LR2. Now for 3, 4 and 5, we are going to use this table. I want everyone to be a little bit more interactive. I will be just giving you a lot of clues here, but definitely if you just practice these next few cases, you will be able to do Lirads on your own once you finish this lecture. So you can see that again, just to brief up, 5 major criteria on the sides: arterial phase category and no arterial phase enhancement. So we have some interactive cases. So in this particular case, what do we have? So we have the cirrhotic liver here, and you can see there is a small lesion here which is hypo-intense in T1, just like the ascitic fluid. It is hypo-intense. And how is the lesion in T2? It is totally bright, very clear fluid-like thing, like just the rest of the ascites. So hypo-intense, hyper-intense. And then in diffusion, there is no restriction. And on contrast enhancement, you can see a nicely seen hypo-intense lesion, but there is no enhancement whatsoever. No enhancement in the venous as well as no enhancement in the delayed phase. So what are we dealing with? Anyone can just put a message in the chat box. What are we dealing with? We are dealing with is simple cyst. Yes, I think I got the right answer. I think that we are dealing with a simple cyst. You can see that. So simple cyst, as you know, very clear in our images. So we are going to tell it is LR. We are going to tell this as LR1. Perfect. I think few of you have already got it right. So so this is LR1. Then coming to the next category, 45-year-old patient with a lesion which is hyperintense on T2. Okay, hyperintense. This is a T2. You can see that there is a CSF around the cord is brighter here. So there is an hyperintense. So this lesion is particularly called as intensely hyperintense. We also call this lesion as a bright bulb sign, right? Very bright bulb sign. So, and this lesion is hypointense in T1. So this is looking more like cyst, but what is happening in the contrast phases? In contrast, you can see that the lesion starts showing some peripheral enhancement. You can see there is a peripheral. There is not a complete rim, but an interrupted little peripheral enhancement here. And then in subsequent phases, it starts filling in. So, so what is the diagnosis here? So this is very good. Like this is classical of hemangioma. You can see the lesion, nicely centripetal filling is there, and I'm already getting answers in the chat box telling that it is hemangioma. So this is very classical of hemangioma. So you are very sure as a clinician, as a radiologist, that we are dealing with a benign lesion. So it's LR1. Now coming to the next case, that is 61-year-old male. You can see the liver surface irregular, the poor signal intensity pattern, and T1 and T2 weighted images, and the nodules are too hypointense, tiny nodules, and there is no restriction, no bright lesions in the diffusion weighted images. And then we have the arterial phase where there is no enhancement of the lesion, no washout, right, in the venous or delayed phase. So whenever we are dealing with this lesion, cirrhotic liver, multiple nodular lesions, and the nodules, especially if they are hypointense, so we know that these are all regenerative nodules. So they fit under the category of LR2 nodules, right? Now coming to the next set, that is the 67-year-old female patient. So I will now start giving few clear clues. So this is a 9mm nodular lesion which is almost iso to mildly hyperintense in T1 weighted images. In T2 weighted images, it is hyperintense. It is little brighter, hyperintense. There is no diffusion restriction, but there is a little bit of an arterial phase hyper enhancement is there. Are you able to appreciate arterial phase? The nodule is enhancing well, and as such there is no real washout, no capsule in that lesion. So using this, can we look and try to Lirad it? So what did we see? We saw an arterial phase hyper enhancement. So suddenly we jump into this category here. And what was the size of the nodule? Size of the nodule was less than 10mm. So we will come to this area now. We'll focus on this particular column. And then now next we'll look into how many additional major features patient was having. Did the patient have capsule? No. Did the patient have washout? No. Did the patient have threshold growth? No. So it is a none. So none of these three features were there. So then when we try to look into intersection of these two, this row with this column, less than 10mm with none of these features, it is fitting into what Lirads? It is Lirads 3. I think good. I think Dr. Suresh and Gautam have already answered it. Excellent. So it is Lirads 3, right? So this is how we are going to use, and there are next subsequent cases. I want everyone to really look into it and try to answer them. So this is another 9mm nodular lesion. You can find that the lesion is hypointense in T1. It is bright hyperintense in T2, and it shows here there is, I told you, like a starry sky, like there is a bright in diffusion weighted images. So this suggests some mitotic activity. And then there is, in the contrast, it is showing arterial enhancement, right? It is showing arterial enhancement. Then you have a washout of the lesion. You can see central lesion appearing hypointense. washout, and then there is a definitive capsule of the lesion around it, right? You can see a nice capsule around it. So what are we looking? So we are looking into arterial phase hyperenhancing lesion, and the lesion is less than 10 millimeters size wise, and here we have at least two, like an enhancing capsule is there, there is a washout. So you have two features. So intersection of this row with this column, so it comes down to LR4. Excellent. I got already the answer. So answer is LR4, right? Now coming to the next set of 51-year-old male patient, you can see that there is around 18 millimeter nodular lesion in the right lobe of liver. You can see that there is an artery, the T1, it is actually a little brighter in T1. So this can be possible, like the lesion can be brighter. And then we have the lesion in T2 weighted. You can see that partly it is bright and partly it is hypointense. So there is some amount of differential signals in the T2 weighted image. In diffusion, it is showing brighter than the background parenchyma. So definitely there is some moderate amount of restriction in that lesion. Arterial phase hyperenhancement. Sometimes in the current, they use some gradient which might really confuse, like you can have this kind of hyperintensity in the aorta, please, but don't get confused. So, but these are T1 weighted images only. But you can see that this is a contrast image, same contrast where the intensity really brightens up and the arterial phase hyperenhancement. Then you have there is a washout of the lesion, and then there is a definite capsule of the lesion around it. So 18 millimeter lesion. So you know that you are dealing with the non-rim arterial phase hyperenhancement. Then you are dealing with this category of the lesion, 10 to 19 millimeters, where at least capsule is there and washout is there, two or more category. So we are dealing with which stage, which it is. It is LR5. Excellent, very good. So it is LR5. So this is how you are going to use your diagnostic table for categorizing which Lirads it is. So we have next case. So you can see that you are seeing there is an ill-defined lesion in T1, T2, ill-defined diffusion restriction, and heterogeneously enhancement with some amount of a portal vein thrombus here. So whenever you are dealing with this, you are going to report this as a malignant lesion with a tumor in vein category. Then we have, then you can have a lesion where there could be a thrombus, there is some wedge-shaped infarction, and there is an ill-defined lesion with a peripheral enhancement. So this is like, you know that this is a malignant lesion, and but not typical of HCC. So we are dealing with LRM kind of things, categories, can be cholangiocarcinomas.
क्लास चल रही है, बाद में बात
Now, then there are few set of categories, like even we start applying for post-treatment, post-interventional procedures like microwave, RF, then where we start applying Lirads in those lesions too. So here, see, generally there are two bright lesions, bright in T1 weighted images, like a hemorrhage can appear bright, or if presence of fat in the lesion can appear bright. So you can see that this is a T1 weighted image with a fat suppression. There is bright in a post-treated lesion, so suggesting that there is a hemorrhage. And so this is the T2 weighted image, again a heterogeneous signal. And you can have the hemorrhage can appear brighter in diffusion. Then this is when the contrast study is going to help us. So you can see in the post-contrast study, the lesion, the entire, whatever the hemorrhage is there, is not enhancing. The entire lesion is not enhancing. So there is no evidence of any solid portions in the lesion. So we can be very sure that the entire lesion is treated and it is non-viable. So we are going to use the terminology LRTR non-viable, right? NV. Then I have a couple of more interactive cases, and then we will wind up. Then we have this again post treated case. You can see that there is a presence of hemorrhage here, and there is some cough of hyperintensity and a cough of the diffusion restriction. On contrast images, the entire lesion, entire observation, you can see that a part of the observation is not enhancing, but a part of the lesion has started. There is an enhancement on this posterior part of the lesion. So you know that this is being partly treated. So there could be a viable tissue here. So we are going to report this as LRTR viable. Okay, so these are the various post-treatment Lirads terminologies. Sometimes when you are in doubt, when it is equivocal, you are going to put them as equivocal and then have a short interval follow-up. I think one last time I want everyone to now use your fingers, right? As well as if you want, you can do the chat box of what Lirads it is. So this is 21 millimeter lesion. You can see that the lesion is almost intense to liver, and it is mildly hyperintense in T2 weighted image, and it shows some mild to moderate diffusion restriction, that is bright in diffusion. Then you can see there is an arterial phase hyperenhancement, there is a venous phase, there is washout is there, then there is a capsule here, right? And already I've started getting the answers, but please keep your left hand up and everyone show the figure what really you are looking for. So this comes under arterial phase hyperenhancement. So you can see that it is more than 20 millimeters with both of these features, two features. So this is what this is, LR5. So what everyone, please show what it is. It is LR5. So wherever you are sitting, I think everyone is showing 5 as the answer. So that is the power of Lirads. So definitely teamwork helps in managing these lesions, right? So I hope today's lecture was useful, and so I think I will really wherever you are practicing in your institute, please, I think, start encouraging this, sit with your radiologist, and then we all have to start utilizing this for better treatment decisions. So today, in short, we looked into what are the key pointers to tell cirrhosis. Then we looked into how the focal nodules in the liver, like beginning with the regenerative nodule, low-grade dysplastic nodule, high-grade dysplastic nodule, and then the HCC, early HCC and late HCC. Then 5 major criteria we saw, and then we saw some interactive cases on Lirads interpretation. So please start using them in all your workplace. So with this, thank you all for patient listening. So I think there are few questions which are coming up. Sir, is there a way to differentiate metastatic from primary? See, again, the clinical setting is important. See, metastatic lesions, you need not have a cirrhotic, a cirrhotic liver. So HCCs generally come under a cirrhotic background. And metastatic lesions generally can be, varied form. So sometimes they are hypovascular like colonic malignancies, or hypervascular like we have RCCs, or lung tumors or breast lesions. So like that. And sometimes the metastatic lesions may not follow the same, pattern what we classically describe in HCC, and also use having patient having other primaries as one of the groups. Next question is there any grading for washout? As such, there is no grading. You have to just look for the two things. One is arterial phase hyperenhancement. This should be the two categories: the primary lesion with the arterial phase hyperenhancement. So enhancement relative to that, and also use the background liver. See, what happens is in venous phase, background liver also tend to enhance. So whenever the washout becomes relatively lesser to the background liver, we consider it as washout. And how to differentiate a liver surface deposit from right subdiaphragmatic deposit? I think a very good question. Unless and until you have ascites, it might be difficult. So many times this either the surface lesions, either it could be diaphragmatic surface or the liver surface lesions. I mean, they might be little challenging to differentiate unless and until you have a clear cut fluid or a plane between the two. I think, sir, please tell the features of fibrolamellar variant. See, fibrolamellar, there are 4 to 5 subtypes of HCC, chromophobe types, fibrolamellar type, and all like that. And so, in which the fibrolamellar HCC have the specific appearance. So, essentially, they have what we tell as a central scar. Central scar will be there, and the central scar is generally hyper intense on T2. Okay, so hyper intense on T2, and we can use liver specific contrast agents to differentiate it. Differentiate it, but again, all in all, it will also show, apart from the central scar, can show the features of other, like an heterogeneous enhancement, washout. All those features will be there. Yes, Lirads is mainly for cirrhosis lesions or patients with hepatitis B virus or patients with prior HCC patients. These are the 3 main indications. So, just a minute.
Any more questions, trainees?